Welcome back to Catalyst University. My name is Kevin Tokoff. Please make sure to like this video and subscribe to my channel for future videos and notifications. And a big thank you to my patrons on Patreon for your contributions to my channel. In this video, we're going to discuss screening for depression and suicide risk. So before we get into the details of how this works, I want to show you some statistics here to give you something to look at visually and also something to think about as we go throughout the video. So right here, this is a map of the United States. And what it shows is the percent change in suicide rates since 1999. Now, in the year 1999, the suicide incidence rate was 10.5 suicides per 100,000 people. And that rose in 2018 to 14.2 suicides per 100,000 people. So this takes into account the increased population, and what it ultimately shows is a 35% increase in the suicide rate in the United States. That is not a good statistic. That is not a good look. That's definitely something we need to try and bring down. And then this map here shows two additional things. Number one, almost every single state, to be exact 49 out of 50, saw an increase in the rate of suicide since 1999. The only state that was an exception was Nevada, which was a 1% decrease, but all the others saw an increase in the rate of suicide. And the darker the states are, the higher the rate of suicide increases, as you can see right here. The second thing to notice is as you go from south to north here, the increase in suicide rate is actually getting higher and higher. If you look up here in the north, there's a bunch of states up here that actually saw a 38 to 58% increase in the rates of suicide since 1999. Now, one of the things that may partially explain that is the latitude. So as you go farther and farther north, you tend to have less heat because it's colder and overall less sunlight. And not to digress too much, but when you look at vitamin D, humans can certainly get that from the diet, but a lot of it, actually most of it, we actually make ourselves. And in the synthesis of vitamin D, there's two reactions that don't require an enzyme. That's not common. One reaction is catalyzed by heat. The other one's catalyzed by UV light from the sun. So in other words, as you go further north, where there's less sun and less heat, you're getting less synthesis of vitamin D. And insufficient or deficient amounts of vitamin D correlate with depression, which in turn correlates with suicide rate. The other thing to note is that when we compare veterans, so military veterans with civilians, veterans have a much higher rate of suicide than non-veterans, or what we call civilians. In fact, in 2016, the suicide rate was 1.5 times higher for veterans of the military. So again, that's another thing to watch out for. And overall, we've got a lot of things that we need to fix. But by and large, depression and suicide risk are important things to screen in any healthcare setting. So we'll always start with the screen for depression. The suicide risk, we're not going to open with that, of course, but this is something that would come out of the patient interview and really out of questions about depression. So this is what we're going to start with. And before we go any further, I want to pull up this document right here. This is the Patient Health Questionnaire, or the PHQ-9. You can find this easily through a Google search, but I'll try to remember to put the link to this in the description of the video. But if we look at this, you can see 9 questions right here. There is a later 10th one, but the first 2 questions would probably look fairly familiar to you. Little interest or pleasure in doing things, feeling down, depressed, hopeless. These 2 first questions on the PHQ-9 are the 2 questions that constitute the depression screen. And you've probably seen these on a patient intake form, and this is where they come from. So up here, we got the shortened versions, but the longer versions down here. Number 1, during the past month, have you often been bothered by feeling down, depressed, or hopeless? And then number 2, during the past month, have you often been bothered by little interest or pleasure in doing things? Now, obviously, those both have either a yes or a no answer. Okay. Now, we could have a case where both are no, and that's good, right? The person is not at risk for depression or they don't have depression, in which case we can probably move on with the patient interview. But we can, of course, have cases where one or both of these are yeses. And so if we look at the case where there's one negative response, and by negative, I mean just a bad response. It's a yes, right? the probability of severe depression actually decreases from 20% to 5%. The 20% here is the pretest probability of somebody coming into the clinic and presenting with severe depression. But again, if they have one yes only, that probability actually decreases to 5%. Okay, that's based on statistical data. But when both of these responses are negative, so bad, so 2 yeses, the probability of severe depression increases from 20% to 50%. Okay? Now, even though for one yes, the probability of severe depression actually decreases, regardless of whether it's one yes or both are yeses, we're always going to ask, would you like help today? This is often another question you'll see following those two on the patient intake form. If it's not on there, you should ask it. And the answers to this question are no, they would not like help. Yes, they would like help today. And there's another one, yes, but not today. And so if one or both of these are yeses, we do need to ask this question. And if the depression screen questions are both yeses, in addition to asking if they'd like help today, there's 2 other things here that we actually need to consider. Okay? Number 1 is actually monitoring for any of these signs and symptoms of depression. So we can have weight changes up or down. So loss of weight, gain of weight, changes in sleep. We can either have where they're in a hyper state, so they're insomnia, or we can have hypersomnia. So they can either have too little sleep or too much sleep. Psychomotor changes. They can either be agitated or they can kind of have a flat affect, just very out of it, fatigued, and so forth. Obviously fatigue. Negative self-feelings. These are things like feeling worthlessness, guilt, etc. Difficulty concentrating and thinking. And then here's one that's really bad, suicidal ideation. In general, if 3 to 4 of these or more are positive, that's where we need to start thinking, yeah, we should probably refer this person out to the appropriate professional, whether it's a psychologist, counselor, etc. But if they have any indication of suicidal ideation, even if there's not 3 or 4 of these, we probably still need to consider referring out to the appropriate professional, because we could be the person that catches that and then the person's able to get help and then doesn't commit suicide. Okay? Another thing we can consider doing if both of the depression screen questions are yeses is administering the full PHQ-9. Again, remember this is all 9 questions right here, and basically the way this works is you have these factors right here like feeling tired or having little energy, and the person scores it 0 to 3, 0 being not at all, 1 being several days of the week, 2 being more than half the days of the week, and 3 being nearly every day of the week. And then basically you just go down here and add up these columns, and then you get a total right here. Okay. With the total, basically come back here and you can make an interpretation. So if they score between 0 and 4, probably not severe depression. If 5 to 9, it's mild. 10 to 14, it's moderate. 15 to 19, moderately severe. 20 to 27 would be severe depression. Again, the higher the score is here, the more likely you're going to need to refer that person out to the appropriate professional, counselor, psychologist, assuming that you've talked with the patient and have their permission to do it. You can't just refer them out, but you should have their permission before you do anything. Now, there are several risk factors for depression that you should watch out for. The first is just a previous history of depression. If the person has ever had a depressive episode in the past, it makes it more likely that they can have one again. Also, if they have a family history of depression, and it really needs to be an immediate relative, so a sibling or a parent, family history of that increases their likelihood of having depression. Women are more likely to have depression than men. Again, it's not saying that men don't have depression, but women have a higher rate of depression, especially during pregnancy or after pregnancy. So you've probably heard of postpartum depression. And then a significant medical history, so 1 or more chronic conditions. We could be thinking of things like Parkinson's disease, cancer, maybe ALS. It could be a number of things, and not even necessarily that severe of a condition. But some conditions may impact the person's ability to remember things or be active or do things that they like doing. And so that inability to do those things can cause depression. And also a significant loss in their life. And this loss doesn't necessarily mean family or friends, like a person. It could be a job. It could also be a significant change in social status or money. There's a lot of things that could cause depression, but these are your risk factors to watch out for. Now, depression does not always equal suicide. Not everybody who's depressed is going to go and commit suicide. But in your patient interview, if the person expresses anything remotely resembling suicidal ideation, that's where you need to really delve into that and potentially get that person help immediately. And the important thing to know about suicidal ideation, it's not just saying, I want to die, I want to commit suicide. It can be much more subtle than that. So some red flags that strongly rule up the fact that somebody may actually attempt suicide are statements like, I don't know how much longer I can take this. Or if they express thoughts of death, wishing they were dead, or if somebody stops their treatment or therapy, especially if they were making improvements or there is room for improvement. Any one of these things may actually indicate that the person is at risk for attempting suicide. And actually these last two things right here, if they express thoughts of death or express wishing they were dead, those two things right there have a really high sensitivity and specificity for attempting suicide. Now these red flags should make your radar start beeping really fast. But then there's other red flags. This isn't technical, but I would think of them as severe red flags or redder flags. These are very, very bad. And these are when the person has a plan to commit suicide, or they have the resources to do so. And the most common resources are a weapon like a gun, and also prescription medications, especially if they just had a refill. Oftentimes someone will attempt to overdose on medications. And so if somebody expresses they have either of these things, this is a case where you need to act quickly and know who in your clinic you need to contact. Okay? So now for risk factors for suicide. One is gender, and depending on if you're male or female, there is a different rate of completion of suicide versus attempt of suicide. So for women, there's a higher rate of attempt for suicide. So that means that they attempt suicide more, but they don't actually complete it. They don't actually kill themselves more. They just attempt more. Men don't attempt as much, but they have a higher rate of completion of suicide. That's a big thing to understand. Also, people who have a history of living alone, it could be that they just live alone because they're never married. It could be they're no longer in contact with their family anymore. There's a lot of reasons that people can be alone, but people who live alone have a higher rate of suicide. Either mental or progressive illnesses. So people who have mental illnesses are more likely. People with progressive illnesses, this goes back to that significant medical history. One example of a person who committed suicide that had a progressive illness was the late Robin Williams, a comedian. He was actually found out to have had Lewy body dementia, which is a type of dementia that actually has some overlapping symptoms with Parkinson's. It's not Parkinson's disease. It's still a dementia. And he actually committed suicide. Whether it actually changed his mental status or he didn't want to be a burden to people, it wasn't known. But again, that's one example of a person who committed suicide and they had a progressive illness or a chronic condition. A previous attempt, if you've attempted before, it makes it more likely that you'll attempt again. If there's a recent loss, whether it's death, loss of a job, change in social status, etc., those all increase the likelihood of committing suicide. A feeling of hopelessness, that goes back to kind of the negative self-feelings. So hopelessness, feelings of worthlessness, guilt, etc. And also the family history of an attempt. If someone in your family has attempted, it makes it more likely that you will attempt. So as we conclude this video, I want to mention that this is a very, very important topic and something that's very important to screen for. You may very well be the person that catches somebody's depression and potentially suicide risk, and depending on how it's handled, you may actually have saved a person's life. So it's very important to do. And not screening for these things is a disservice to our patients in whatever profession we're working in. But in any case, I hope that you learned a lot about depression risk and suicide risk and how we screen for those things.